Good evening and welcome to MedStar Health and New Old Age, Caring and Coping. It's a live webcast. And I'm Jamie Costello from WMAR ABC 2 News here in Baltimore. And we're here tonight broadcasting from the Inn at the Colonnade in dear old Baltimore. And if you're watching us on your computer or your device, I'm looking for your comments or your questions. You can post them in the chat room or MedStars Health's Facebook, or on Twitter. You can use the hashtag AskMedstar. This is quite a topic here tonight. You know, on Valentine's weekend, my wife gave me anti-aging soap, anti-aging cream, shaving cream, and look, today I look the same as I did yesterday, so it must be working. We're going to be talking about a variety of subjects here tonight. Among the topics, Alzheimer's. We're also going to talk about behavioral changes, preventing falls, caring for our elders, and also end-of-life issues. But let's start it right now. Let's meet the esteemed panel that we have with you. George Hanawi is the director. Dr. Hanawi is director of geriatrics at MedStar Good Samaritan Hospital, medical director at the MedStar Good Samaritan Nursing Center, and director of the Center for Successful Aging. You will show us how to age gracefully and successfully. Thank you, doctor. Next up, Dr. Elias Shaya, Chief of Psychiatry for both MedStar Union Memorial and also the MedStar Good Sam. Thank you, doctor, for joining us. And MedStar Good Samaritan Hospital Senior Physical Therapist, Judy Bopp. Hello, Judy. How are you tonight? Great to see you. Next, Dr. Christopher Kearney, Medical Director of Palliative Medicine for MedStar Health. And lastly, we have Adrian Kirby, a geriatric social worker at MedStar Good Samaritan Hospital. All right, let's start. Dr. Hanawi, first off, just tell us what geriatric care is. We'll start broad.
Let me take back the origin of the word. So geriatrics is a Latin word, and actually it's two words. The first one is geron, which is older man, and the second is iatros, which is healer. So it's the healer of the older man. Practically, it's caring for older adults and their unique healthcare needs throughout the journey of aging, from preventive health to successful aging, all the way to chronic disease management, geriatric syndromes, which are very unique to older adults, going to functional decline and the inability to take care of daily chores, driving that all the way to advanced care planning and end-of-life issues. That's what geriatrics is all about.
Well, what is the life care plan then? Take us through that.
Yeah, it's a great question, and it's dear to my heart, and I want to put this into perspective. So the U.S. population is growing older, as you all know. 10,000 baby boomers are turning 65 every day, and they're going to continue to do that for the next probably 10 to 12 years. The challenge with the current care, it's been interrupted, it's been episodic, it's not coordinated. Knowing that our Asian population have a lot of chronic diseases, an issue that comes with age, we are looking for a different direction of care. And the belief in the geriatric community and the belief in the Center for Successful Aging is that the best way to achieve better care is by moving toward what we call person-centered care. We have to stop seeing the patient as a patient and start seeing them as a person. The life plan is a direct connection to that. It's practically creating care plans that are based on the person's values and preferences, that starts in our center and kind of connects with them through the journey of care. And if I can take a minute just to give an example of one of our patients that helped us design a care plan. It's a gentleman, Mr. C, that I met about 3 years ago. He had multiple chronic diseases, and he came and said that, my preferences are related to being at home, not hospitalized. I don't want to have major interventions. How do you guys can help me? So we understood that, and we worked with his family on achieving those. So when he gets sick, we'll take care of him at home or in the office. We avoided major interventions. We avoided major hospitalizations. Mm-hmm. But the key issue is when he got older, his mental status was not as sharp as it was. He wasn't able to decide. The family and the team from the Center for Successful Aging were very clear about his goals. We knew that he wanted to be at home. We knew he didn't want any aggressive intervention. We worked hard to get that taken care of, and we were successful achieving it because he planned it for us. That is a true demonstration of what we call a life plan. And it's something that we try to do for every patient at the center.
Everybody wants to drive. There's nothing wrong with me driving. I can get behind the wheel. I can go out last night on those icy streets and I can make it home to the grocery store in no time. How do we stop them from driving before they injure? You know, it's one thing to injure themselves, but if they injure somebody else. Carol Wheatley from the Adaptive Driving Program at MedStar Good Samaritan. How do we know to say, give me the keys?
That's an excellent question. And they have done research that has analyzed the crashes that older drivers have had so that they've been able to identify a number of different types of problems that become indicators or red flags of when a person needs to be able to think about stopping driving or stopping altogether. So examples of that would be having difficulty confusing the gas or the brake pedal, or stopping for no apparent reason in the middle of traffic. So those would be some examples. Another one would be if a person starts getting lost in familiar areas that they've been driving in for quite some time, and now they're starting to have problems being able to find their way or find their way home. So sometimes we have patients that recognize these problems in themselves, but there are other times when they don't have that objectivity, and family members or a physician or a friend or another allied health worker might be the one to point out to them that they're starting to have a problem. And one of the advantages of having a driving evaluation is that we can be objective because just meeting the person for the first time, we have a number of standardized tests that we can use to help us to indicate where their strengths and weaknesses are. Is there anything that we can do to be able to help that situation? Or on the other hand, is it time for them to stop?
Yeah, pass the buck on to the MVA. Let them tell the
That's
mom
exactly
and dad and
right.
give it up. And you said, you know, they took us to Glen Burnie to get our license when we were 16. Now it's our time to take them to the MVA, get them. Is there a cost to this, Carol?
There is. When you set up a referral, we need typically a doctor's referral for this. There is a cost. There are some companies and funding sources that are available. The Veterans Administration, for example, or the Hartford Medical Insurance is one insurance that will cover it. But the majority of the people that I see are people that are paying out of pocket for this service.
Who gets the test results then?
I'm sorry?
Who gets the test results?
The test results are given to the referring physician, and if the person has a medical condition that is reportable to the MVA, or if there's a serious risk or safety concern about their own driving safety as well as the safety of the driving public, then in that case the MVA would also get a copy of the report. And we have the person sign a consent form up front so that they're fully aware as they're coming into the evaluation that those reports are going to be sent to those two sources.
Great job, Carol. Thank you. You're driving us all home tonight. Thank you very much. All right, Carol. Let's go to Dr. Shaya now. We're going to talk about, it's a senior moment. I can't remember. Where did I put my car keys? Just a matter of, describe us, doctor, the stages before we're having that senior moment to actually having Alzheimer's dementia.
That's a great point. Is do we get alarmed when we have what we call senior moments, and when should we actually do something about it, and when is it just a matter of forgetfulness that all of us experience as we go through the day? We are distracted by so many different factors, and we have so much to do, especially nowadays. The cell phone is going off, the email is not answered, you have a meeting here, you have to cook, you have to do all of these things. It's easy to forget, so it's very important for us not to be alarmed about these forgetful moments just anyway. When it becomes a persistent matter, when it becomes something that gradually gets worse, when it becomes a matter that others are noticing, when it starts interfering with daily life, when it starts impacting our function, that's when it is probably worth checking into it further.
Mood swings?
Mood swings are sometimes a complication, of course, with age. There is not really an increased risk of that for I think it is very important for me to say here that, in fact, our elderly population is the happiest population epidemiologically. So from a statistical standpoint, older folks are happier. It's not where we have the worst mood swings in terms of the age group. However, it is important to note that mood swings, behavioral problems, depression can be complications of dementia. If we are into that stage of dementia, And the forgetfulness is no longer just a mild little forgetfulness. It is really a serious problem we need to pay attention to. It can be complicated by other
We'll open up
conditions.
the floor here to any questions, because this topic is the Alzheimer's is just a dreadful, dreadful disease. And to see somebody just not know who you are or what they did yesterday, it's just terrible. So if you have a question about that, please, these are our panel of experts you can ask, and also ask online here. We want to go now, each year at least 250,000 older Americans are hospitalized for hip fractures, and more than 95% of hip fractures are caused by falling. And for elderly patients, a hip fracture can be life-threatening. So Judy Bopp has some tips, man, about the hip.
Yeah, well, just the first thing to realize is it's not usual to fall. So it's something that don't expect because you've gotten older that you're going to fall. You shouldn't be falling. And some of the percentages of where falls occur, they're very most likely occurring in your own home. And if they're not in your own home, they can be right outside your home or not far from your home. So one of the first things we need to do is see what we can do to help prevent you from falling. And there are some things that are intrinsically happening that you can't control as well. So some medical conditions, if you've had some changes in your cognition, your hearing, your vision, then you have to watch that. Chronic diseases that you have to watch, if you have Parkinson's disease or a stroke, there are obviously risks for falls. But there's also some extrinsic factors, the external things that can cause you to fall. Things like medications. Are you on too many medications? Do the doctors know which ones? If you see more than one doctor, the interaction between the medications. Alcohol, obviously. Hopefully everyone behaved tonight, but if you had too much, you're at a risk for falls. Environmental hazards within your home and outside. Things like clutter in your house. They can cause you to fall. With our recent snowstorms, the ice, things like that you have to watch. So they're all things that we can address and help try to prevent you from having falls. So what you can do is make sure you get yearly assessments, have your doctor see you, review your medications. If you wear glasses, get them adjusted each year. Make sure that you can see what you need to do. And then if you have any major issues, your doctor can refer you to a physical therapist to have an assessment for your balance. And in a minute, I'm going to show a little test to do to try to see. You want me to do that now?
Yeah,
okay.
come on. Save
Carol's
our
going to
hip.
be my assistant
All right,
up here.
You're not going to fall down, are you?
No,
Okay,
that's why these
all right.
stools are very risky for me, so I have to watch them tonight. So one of the ones that we do, it's a standard test. It's called sit to stand 5 times, and you just have the person sitting in a chair, no armrest for them to use. They cross their arms over their chest, and then we time them standing up and sitting down 5 times, and we have norms as to what the time should be. So Carol, you ready? Go on up and go. That's 1 and down. 2 and down. Keep going, quick as you can. 3 and down. 4 and down. And 5. And I timer.
Huh.
And if you should be able to do that in about 15 seconds. And anything below that puts you at a risk for falls. The longer the time, the higher the risk for falls. So we work on things for exercising to help people so they can do that. So speed of your gait is very important with your risk for falls.
How about lack of balance? Somebody that just does
We
not
have plenty
balance.
of things. Yep, and there's exercises you can do for balance, and we test the same way. We'll do the feet together test, where you have someone stand with their feet together, cross their arms over their chest. They have to stand that way for 30 seconds. You then have them close their eyes and see how they respond with their eyes closed, because when you don't have that visual input, it then makes it difficult with your balance. Then we can do single leg stance, where you have someone stand on one foot, cross the arms, and time them that way. And again, there are normative data out there that tell us if you're below a certain time, you are at a risk for falls.
Man, it's all about flexibility too. How they can,
Yep, that's where having the physical therapy evaluation to make sure that you have the flexibility of the ankles and the hamstrings and everything. So you have those protective responses that you need in order to protect yourself if you lose your balance.
All right, 5 more for you, Carol. Go ahead. I'm serious. Go. 5
No,
more.
no, we only do it
that's-
once.
Oh, you only do it once. Oh, look, okay.
Only once, only
Just
once.
be careful. Be careful. Put in that chair. Be careful. Okay, easy.
There you
Yeah,
go.
that's
She's
good.
in good shape.
All right, very good. Thank you, Carol, for doing that. That's great. Why is it always the hip, though?
Well, and one thing I didn't point out before, with getting screened, to see if you have osteoporosis, which is the weakening of the bone, and the hip is a very common place for that weakness. So when someone does fall, they land on the hip, or sometimes it's actually the case where they have the weakness and the bone fractures and they fall down from that. So it's very important to be tested for the osteoporosis and make sure you get enough vitamin D and calcium, especially females.
All right.
So.
And Judy's also proposing that when you get to be 42, everybody moves into a rancher. Is that right? One floor?
Steps are tough, but they're also good exercise.
That's good.
So
All
yes,
right.
yes, there
Judy,
you go.
great. Thank you very
You're
much.
welcome.
All right, Dr. Kearney, your turn. Listen, we've been talking about improving the quality of life. Tell me about that. Tell me about the quality. It's not the same as what you do. It's not the same as hospice. So describe what you do.
That's
with
correct.
that.
We're still interested in improving the quality of life as well, though. So there is, palliative medicine is my specialty, and hospice is a subset of palliative medicine. So most of the people in this room have some idea of what hospice is. That's it's a federal insurance program. It's part of the Medicare program. In order to be a hospice patient, two things have to be true. One, someone has to say, if things go the way they look like they're going, your time may be short, 6 months or less. No guarantee, and you can outlive that. The other thing is that the patient or the patient and their families have decided that care and comfort are really the goal. So in general, you are giving up the next trip to Good Sam or Union Memorial Hospital. You are not opting for further chemotherapy, surgery, and the like. Palliative medicine is a larger field, a newer field. It started probably in the mid-90s in this country when they did a large study called the SUPPORT study, where they demonstrated that we were actually giving very poor care, even in very prestigious institutions, for people who are seriously ill or dying in our hospitals. So it became as an inside the hospital institutional specialty. It's starting to grow from there. They're partners with hospice, and I partner every day with hospice, but the patients I see typically are seriously ill. They still, however, can be receiving treatment. They can be getting chemotherapy. They can be getting treatment for their hearts, their congestive heart failure, their COPD. They can still be on dialysis. They can still be going to surgery. That still, in my mind, they are still benefiting from palliative services. As George pointed out, we're talking about the whole person and not just the medical condition. So the time they give you your diagnosis of stage 4 lung cancer, your life just changed entirely. Your life, your family's life, the suffering, all these things have already started, even though you're going to be treated for chemotherapy and may benefit for some years. There's a time where you will run out of good therapeutic options, and then the palliative part becomes a larger part for your care.
That's a difficult decision.
It is a difficult decision. The desire not to be dead is pretty strong, so most of us will do an awful lot not
How
to
do we
have
ask
that.
to see you then? How do we ask for this care?
Most hospitals now have palliative care programs. Again, unfortunately still limited to inpatient, so there's not a lot of outpatient palliative care at this time, but families often ask for it. They're aware of it, availability, and the knowledge of it is now there.
Coming in from Facebook, good question here. When do we know it's time to ask?
When the burden starts to outweigh the benefit for most people. So again, the type of diseases that we see regularly are cancer, congestive heart failure, and COPD. These are people that are often in and out of our hospital settings. The question is, in my mind, is what's the next hospital trip going to mean? Is this still beneficial? Is it meaningful? Is it even respectful? So we are seeing a lot of patients who are last stop is hospital. I raise your hand in this room. Who wants to die in the ICU? No one. So that's what happens, though. Unfortunately, your chances of dying in hospital is still pretty high, all of us. So it's a continuing challenge.
Wow. All right, let's move on to Adrian. This is the tough one. And I can vouch for this because I had 2 small kids. 3 o'clock in the morning, I'm getting the call to go pick up my mother off the living room floor. And I had 2 kids I had to get to elementary school, and it just drove, it's horrible. It's just horrible to be a caregiver. And there are ways that you can really give the care you need and not feel guilty. I mean, there's a lot of guilt in this, isn't it?
Yes. Yes, there is.
Tell me about how do we manage to live our lives over here, but take care of the people that gave us our life?
Right. Yeah, you can experience a lot of guilt. It's a hard job, no question about that. You can find a lot of joy in caregiving, though. Even when other things may fall aside. But I do have a few general tips
Go.
for caregiving. So to make caregiving easier, something that's really important is to make sure that you're not spending all of your energy as a caregiver. That's kind of where the guilt comes in. Sometimes it feels wrong. Leave someone with another person they don't know as well and go do something, but it's really important. It's important so that you can be well to care for someone. Another thing is to ask for help, and that is really hard. A lot of people find that there's one family member who's the primary caregiver and they feel embarrassed or uncomfortable asking other people for help, but many people, you may be surprised, are much happier to help than you think. It's important to ask directly and give specific requests, like, will you stay with mom and read a book to her while I go out to dinner? That's easier than for someone to understand and agree to. And then another tip is to join a support group if talking to others is something that makes you feel better. You can get a lot of great advice from physicians, social workers like myself, physical therapists, but there's really nothing like sitting in a room with people who are doing the same thing you're doing, and they know things that we may never know. They may have a great tip for some issue that you're facing. And another thing I wanted to talk about is how to find resources. So there might be some programs in the community that could be really beneficial, but it's kind of hard to find out about them. So some good places to find out about those resources are the people that work at your doctor's office. At our office, we have the advantage of having nurse practitioners, physical therapists, physician assistants, and social workers who really know a lot about different areas. At your place of worship, just talking with friends, especially if you know of older adults or people who do have caregivers, they can be great resources because they know about things right in the community. If you have a neighborhood association or if you are involved in a senior center, these people deal with caregiving and aging every day. So they probably know a lot too. And then your county's or city's Office on Aging is also a great place. They have a lot of information about programs and resources.
Adrian, I want to ask you a question here.
Yes.
Let's say mom gets up at 8 o'clock in the morning, pops the first pill, falls asleep, wakes up at 10, thinks it's a new day, pops the same pill again. How do you, and I know we have the pill boxes out there, but how do you stop them from over-medicating or combining all the medications at once?
Yeah, that's a tricky one. If you find that sometimes people can set up reminders. I know I've spoken with family members who would call, morning, breakfast, lunch, and dinner. Mom, take your pills on the phone right now so you remember. And sometimes, actually, medication difficulties are one of the ways that we know that someone may actually need more help than they have. They might need more supervision, someone to keep an eye on things. At some point, you might need to have someone hold the pill box and only give it, administer the medication, really, if someone just isn't able and is medicating themselves incorrectly.
Man, that's a tough one. Let's go to Dr. Kearney. Here's a good question for you, doctor. This is tough. This is tougher than your medical exam. Ready? What's the difference between a living will and an advance directive?
An advance directive, a living will is part of an advance directive. So an advance directive has two parts to it. The first part, the most important part, is the appointment of a healthcare agent. We used to call them power of attorney for healthcare, but it's now called healthcare agent. That's the person that you would want to identify who would speak for you when you fall out in the giant parking lot and are no longer able to communicate your wishes. And they need to understand what you want done when things are more serious. The living will is a second part. It's now in Maryland called healthcare instructions, but it basically says if I get in this shape, I want that done. If I get in some other condition, I might want something else done, i.e. if I'm in a terminal condition, would I want to be on a ventilator or have resuscitation done? No. If I am in a terminal condition, would I want a feeding tube placed? Would I want to go on dialysis? Those are the kind of questions that are asked. So a living will is a written document that instructs the healthcare agent. We like to see both. We rarely see both. I'm happy to see a healthcare agent appointed if we can get that. That's a very useful document, and everybody in this room we can close our eyes and say, who in this room has appointed a healthcare agent? So maybe a sixth, not too many. I have.
You have.
So they're very important documents. They do not solve all problems, we know, but they're very useful. They can come into conflict in hospitals. Sometimes we'll have someone say, I know, my mother, told us that she didn't want any of this, but I can't let her go, and I'm her healthcare agent. So it can get very tricky at some level. You have to say, well, your obligation as a healthcare agent is actually to follow your mother's known wishes. You're stuck, just like the rest of us, and even though the end result will be her death, that you're obligated to follow that.
How do you get those documents?
You can create from the state of Maryland. There's all sorts of versions of this. The 5 Wishes is well known as a very good document, more elaborate document. The state of Maryland has them. They're online. Basically, every hospital has them. Pretty much every doctor's office has them too. This is a kitchen table document. You can sit down to appoint a healthcare agent. You don't need a notary. You don't need an attorney. You need your loved ones is who you need to sit down and talk about it. So that's what that's about.
And Jamie, if I can
Yeah, go
follow
ahead.
on what Dr. Kearney and
Yeah.
Adrian have started, is that the biggest challenge with caring for older adults, and I'm going to connect with what Dr. Kearney was saying, is the fact that there's a time when you find yourself feeling guilty about making a hard decision for a loved one, mom, dad, or any of the relatives. So even though we have the privilege of taking care of our parents, and let's say we're 65, taking care of ourselves, but we have also the conflict of, do I call all the shots for those complicated medical decisions, whether they're dialysis or chemotherapy or end-of-life decisions? And to connect with what Dr. Kearney was saying, it's very important for us and for our parents to plan all this as early as possible so the loved ones are not placed in that position where they're feeling very guilty about delivering this or withholding this or doing any of that. That planning kind of makes it a lot more dignified and a lot easier for the one caring for an older adult. That's what the advanced directive is all about. That's what the life plan is all about. That's what the MOLST is all about. And we encourage everybody to think about those things as young and as healthy as you are, because you'll be doing your parents a favor, and you will be doing yourself a favor, and you will be doing your kids a favor.
Dr. Shai, I want to talk, can you tell me about the transition from being a kid to now being over the parent and just looking at mom and dad saying, you're not mom and dad anymore. I have to make some decisions. Can you talk about how tough that is? Because mom and dad always knew it was right.
Of course. And they tell you that even when they can't.
That's right.
So it's certainly a challenge, and somewhat similar to what Carol was pointing out when it comes to taking that car keys or take over the medication or take over the confidentiality at the doctor's office or really reach that tough decision of making modifications in the home. If indeed the parent is reaching a point of dementia, is what we call dementia, and they are struggling with making decisions. And one of the most important features of dementia is actually losing the capacity to make decisions, losing the capacity to reason. And in that case, the child finds themselves having to make those decisions for them. And unfortunately, that is a common source of challenge, of tension, not only between the parent and the child, but frequently it creates dynamic amongst the children themselves, because you have one child who prefers one way, another child prefers another way. When you are making changes, parents need more help. Some children live nearby and are able to provide it. Others live far away and can't really participate as much. All of that is part of the process. And of course, the stages of dementia dictate this. Earlier stages are milder and don't require as much intervention by others. As we progress in the disease, it becomes more challenging. The effect on our daily function becomes much greater, and then we have to come up with alternatives. Frequently, it is the children who have to make those decisions.
Let's go to Adrian real quick, because I want to piggyback on what he just said. If there's 6 family members, you get 8 different opinions on how to do with mom and dad. And it's always
Right.
the person that's local that's got the burden, right? How do you even it out a little bit?
Yeah, that does happen a lot. Sometimes family members who live further away or who have busier schedules can take on other caregiving tasks, like maybe someone can manage the finances from afar, pay the bills. Maybe someone can provide financing for help with caregiving, like to hire someone in the home to relieve the person who's actually doing the day-to-day work. And that's in an ideal situation, and even the most unified families develop tension here. So it's a great idea, I think, for multiple children, siblings, family members to come to the doctor's office, which is something we do a lot, and have a meeting so that so everyone can be on the same page and kind of talk with a neutral third party about how best to care for mom and dad.
Or we ship mom off and say, hey, pick them up at the airport. They'll be in baggage section C here.
Try to avoid that.
To your point, just to follow up on Adrian's point again, to your point, Jamie, the burden really falls on the shoulders of the family. And while we talk frequently about the diagnosis and about the treatment and about the patient, where the real focus is truly the family. And one of the statistics that came out in 2014 is from a cost standpoint that is being provided by family to our society is a massive, over $200 billion of time, informal service that is being provided by those families to our loved ones, to our parents, and that is a massive resource, and it is important for us to recognize that impact. Imagine if that were not available, and as our society is really changing and families are not anymore living in the same neighborhood, extended families are spreading out, it is much more challenging to do that nowadays, and I'm not sure we have a great answer for it. So, but it is important to recognize that contribution by families as it's been looked at and computed.
And would you say it's accurate to say, both either George or Laz, in terms of dementia care, diagnosis is a clinical diagnosis that you both make and I make as well. The treatment we know has been disappointing, so dementia care turns out to be more what you're talking about here, which is the educational aspects,
Yes.
preparing families for what is coming their way. Peter Rabin's book, The 36-Hour Day, for instance, would be a perfect text for a lot of families involved in caregiving. But it is a disease that, unfortunately, treatment is not a strong suit.
Excellent point. That's why I was saying the diagnosis and the treatment are not as much the focus. We're making progress. There is hope. There are developments, but we're not there yet. What we need today is what we can do to support the family who is essentially providing most of the care. We spoke about with one of the members of the audience earlier today whose focus is on education. I was pointing out that really that is the most important intervention of what we do, is educating the community, as Dr. Kearney is pointing out as well, because our treatments help, and I don't think we should discount what they can do. For some patients, they do a lot, and they make a huge difference, and we can talk about that in a minute as to what difference there is there. We should not lose the hope in that. We should not lose the value that treatments do provide, but really the bigger aspect of the intervention is for the family.
Adrian, what'd you have for lunch yesterday? See? Doctor?
Yogurt, I have it every day, so that I
Okay. What'd you have for dinner last night?
Well, I actually
You
had
don't know. All
leftovers.
right, Judy? Chicken? Doctor?
I don't remember.
See? Pizza. All right, Dr. Cynthia Fields is next. Listen, we have so much to remember. I can remember the 1966 Orioles lineup, but I can't remember to bring milk home tomorrow night. I mean, so can you give us some expertise here on how we can keep our memory and how we can keep it going upstairs?
Oh, I thought you were going to ask me a different question,
You
Jamie.
can
But
you can answer anything you want. See, I forgot the question, so there you go. No, what is
Yeah,
it?
so-
Tell us about treating memory loss. How do you treat it?
So the first thing is a proper evaluation of memory loss, really to come up with a diagnosis, or at least what you think is an appropriate diagnosis diagnoses reveal themselves over time. We don't always know as physicians the first time that we meet a patient essentially what's going on, but we follow patients over time. But really the first thing is to have someone who is skilled in the evaluation of memory loss and potentially dementia, to see that person for really a comprehensive workup. And so at Good Samaritan, we are developing a program that's multidisciplinary, that's geriatric medicine, geriatric psychiatry, that's me, along with social work. And we get a lot of history from patients when they come, and some informants, so ideally a family member or somebody that knows the patient well. Lots of history. So what have you been seeing? Trouble with remembering recent events, trouble finding words, getting lost while driving. When did those symptoms start, and have they gotten worse over time? And we try to get an idea of functional impairment, so trouble managing medications, trouble with bill paying, because that's really important to know if this is normal aging or not.
I have
Functional
trouble with all
impairment
that
really
right now.
separates normal aging from not, this functional impairment.
How do
and
we stop it? How do we put the brakes on?
Oh, how do we put the brakes on? The biggest piece of advice that I can give is to control medical conditions. So what we call vascular comorbidities, so diabetes, high blood pressure, high cholesterol, to keep active physically, so regular exercise. That's really the bang for the buck. And to keep active mentally, to try learning new things. Just as an example, there's all kinds of different data about specific things like crossword puzzles or luminosity or whatever, but something that you enjoy that's not overly stressful, but that's challenging and can really keep the brain active. But that physical piece, that physical activity, is really key. And along with that, we hope to see things like improvement in blood pressure, diabetes, cholesterol.
You know, we take driver's tests, we take exams, the bar exam to get in to be a lawyer and stuff. Why don't we have a baseline, like 18, we go in to see a doctor and find out what our mental capacity is, and have that as a baseline throughout the rest of life. And every 4 years we go back in to find out, hey, we've still got it. Why don't we do that?
Well, there should be some baseline cognitive testing as part of a Medicare annual wellness examination, ideally. But we all know that primary care doctors are really pressed for time, and not everyone goes for regular physicals as much as for sick visits.
Right,
So ideally, there is some baseline and there is some following over time. But that's just one piece. The results of a screening test are one piece. That doesn't give history like trouble with paying bills or medication. That's really where it's at, but that takes a lot of time in a doctor's office, and that frequently takes a specialist to evaluate. Primary care doctors see concern, and then ideally they refer to specialists like us for a full evaluation.
All right, doctor, thank you very much.
You're welcome.
How do we pay our bills?
What are you asking?
I'm asking,
how does someone?
how do we get together to pay our medical bills?
Oh, okay. How do you cover the cost? Is that what you're saying?
The health care and
Sure.
the insurance. What does mom and dad have for the insurance? How do we?
Well,
what's all that about?
Dr. Shai, I think maybe was alluding to a statistic that dementia is the condition in older adults that actually costs families the most, even more than cancer or some other very serious conditions, because the care needs that come with dementia are not often medical treatments. They're often hiring someone to help in the house with bathing, day-to-day things that are not covered by health insurance. So there are, for people with very low incomes, there are state programs that cover these things. A lot of it's out of pocket. So I recommend, in advance, if possible, talking with an elder care attorney to kind of figure out how your finances may be put to the best use.
Okay.
There are some other programs, either state, county programs, or nonprofits that can help to cover the costs, as well as the VA.
Dr. Shia, let's go back to Dr. Shia. Best way to help a senior who is angry and agitated, and the signs of dementia are all right there. I mean,
Yes.
how do you get over that?
Well, unfortunately, 80% almost or more of people with dementia at later stages, especially of the disease, end up developing what we call neuropsychiatric complications, whether it is depression or other types of manifestations. One of them is anger, and the anger could be for a variety of reasons. It could be that they are misperceiving something, they misplaced something, and they think you stole it, or you took it because you don't want them to have it, and they're angry because of that, and that will take a different type of intervention as compared to another form of anger that is what we call emotional discontrol, that capacity of the brain to recognize what is emotionally appropriate and what is emotionally inappropriate is lost. In the same way other things are lost. So the reaction, the emotional response, is not explainable and not controllable. And as a result, it becomes quite challenging sometimes. Frequently what helps is distractions. Just anything that you know a parent is likely to enjoy doing. Just take them to the side and just out of the clear blue sky, if you just come up with any distraction that you know they might like, because they don't know why they got angry, they don't know why they forgot it either. So they kind of move along with you because now you have a new thing that they are more interested in, and that's going to take their attention. So sometimes those behavioral interventions are quite effective, actually, more effective than the ultimate tool that we use, which is medication. And we do use medications when things get out of hand, and unfortunately in certain circumstances a patient may become violent. They may become, so we have severities, right? So the milder form of a disease could be managed behaviorally, and luckily we are able to do that very, very frequently. The extreme cases, and that's a less frequent situation, we do have to use medications. Those medicines are not great medicines. We don't have very good medicines for this. We use them because not using them is more dangerous, but they are dangerous nevertheless, and we have to really be mindful of that, and we do the best we can to counsel the family when we are using those medicines to make sure that the potential benefit outweighs the risks. And I do want to follow up on something Dr. Fields had pointed out a little bit earlier. That is why at Good Sam and at our center, again, in collaboration with the Center for Successful Aging, we have that collaborative team, we have that integrated care, because sometimes that anger that we're talking about could be a result of a urinary tract infection, or could be a result of a new blood pressure medicine they are just taking, or it could be a result of the diabetes not being well controlled, or a new form of a new infection of sorts. That collaboration together with the entire team is going to allow us to take a more comprehensive look. That medicine, I'm going to say, is the first thing to point out to. It is common for patients to be taking medicines that affect their memory, that affect their behavior, that cause them to be angry, and that medicine may be needed, but it may not be necessary. And if we can take a critical look at it and possibly do less, I think the average, Dr. Hnawi would tell me probably the statistic more accurately. I think the average person over the age of 65 may have
About nine
different medicines. And I'm sure at some point in time that medicine was needed when the doctor first started it. But when the doctor first started that medicine, it was one medicine. By the time they piled up, now we have 9 or 10, or in some cases 14 and 15. We don't really know how they work together. And if we're having a problem, the first thing I would advocate looking at is those medicines. And frequently things get better by just getting rid of medicines rather than adding medicines.
I like this guy.
Jamie,
hey.
if I can follow on what
Yeah,
Dr. Shaya was mentioning, is the fact that so much of the time we treat the side effect of one medicine with another medicine. And that connects with the area that we were talking about, that, you know, in addition to the neurobehavioral stuff that we worry about with dementia, the most common reason that we place our loved one with dementia at a nursing facility, number one is behavior, but number two is urinary incontinence and stool incontinence. How many of us here know that dementia causes that? And if we don't prepare what we discussed and what Adrian was pointing to, we need to think that if we don't want to place our loved one at the nursing facility and be able to take care of them at home, we need to encourage folks to get long-term care insurance. But the other part is the current system is not developed to support that type of care in the home. That's why we place them at the nursing home. This is why we really need to advocate for a different look at how we care for dementia. We know it's costly, we know it's stressful, we know it's not done the way that any of us want. And if we don't advocate and be the voice to take it to the next level, we're not going to be able to change that gap that we face today till generations to come. So I would strongly suggest that we all get together and advocate for better care for demented folks.
Love it. Love it. Let's go to the floor. We have some questions. Who's got the great question? Here we go.
My grandmother had very severe dementia. She was in her early 80s. I am on 80 is around the corner for me. And I have pushed that worry way down there for years, thinking, I wonder if I'm going to end up with my grandmother's problem. And so I'm very, very interested in this subject. I'm also one of these people that unfortunately, because of blood pressure, irregular heartbeat, I'm on about perhaps 6 different medications. I have a wonderful, caring GP. She doesn't have that label geriatric, but she really looks after her patients.
I think the big question is, does this go down the line? Is it passed down generation to generation?
I don't know if Elias, you want to answer that?
Heredity
Follow?
is certainly a part of dementias in general. It is also part. So we think of dementia. Maybe I should differentiate a little bit. We talk about dementia as being the global umbrella of those conditions that affect memory and affect thinking and affect our function in general. And Alzheimer's disease is only one type of it. It is nevertheless the most common type, but it's only one type. And there are some genetic components to it. So it is indeed inherited. However, most important to remember out of this is the majority are not inherited. So we don't know really how that works. There are risk factors in the genes, but they're only risk factors. So if it is cloudy out there, there's a slightly higher risk that it may rain than if it was totally sunny. But it is not a certainty that it's going to rain if it happens to be cloudy. And the same thing with Alzheimer's disease. We may have a gene that is a risk factor. It does not mean we're going to develop that disease. And that's an important thing to keep in mind. Only a very, very small percentage, maybe just a few hundred families across the world, they have a gene that actually causes Alzheimer's disease. So for most people, that's not an issue to be concerned about. Something you pointed out that I really loved, and I think you're doing perfectly well, and that is the fact to suppress the worry. There is no reason to worry. What there is reason to do is to be aware and to be mindful and to do what you can. It seems you have a great GP who is helping you do that. And you weigh the risks and benefits in life. We do that all the time. We do that when we drink a glass of wine. We do that when we take a drive down a busy road. We do that when we walk our dogs outside on an icy day. I guess always in life we try and balance pain and pleasure in some fashion. There's always some pain that we need to be mindful about, try to avoid, and there's always some pleasure that we're seeking, and we do best when we do that in balance. We get in trouble when we're too focused on pain and avoid everything. We're also in trouble when we're too focused on pleasure and get in trouble.
If I can also tell you that you're doing the best thing to prevent dementia. Dr. Taylor is in the group here and will tell you that a lot of if we look at autopsies of brains of a lot of 90-year-old and all that, so many of them have the pathology of Alzheimer's. But the folks that develop symptoms are the folks that have blood pressure and diabetes and cholesterol that are not managed. So you're doing the right thing by managing your chronic disease. That's how you prevent Alzheimer's. And stopping the worry is the other big part of it, because there's not much that we can do to change the trajectory if it is going to happen, other than staying active, eating healthy, and managing your chronic diseases, especially at the 80 and 90 and before that.
Doctor, we'll stay right there. Explain your center that you run, Center for Successful Aging. That's
right.
Lead us through it.
Okay, it's all what you heard practically. It's an innovative model of care in a state-of-the-art facility that is designed to meet the needs of the Asian population. And when I say innovative model is, again, what you've seen. It's a team approach to healthcare. It's expert in geriatrics, geriatricians, geriatric psychiatrists, nurse practitioners, social workers, physical therapists, occupational therapists, working together and closely with a subspecialist, an endocrinologist, psychiatry, orthopedics, most of the time in one location, to deliver a comprehensive, holistic approach to care. This, we spoke about the life plan. We develop plans and we coordinate those plans through every location of care. And we integrate every member of the family and the community and the resources of the community into that to deliver, again, the same concept that I started, a true person-centered care, because it's our belief it's going to lead us to the next level of care.
We have a couple minutes left, and I just want to go right down the panel again. Give these youngsters all the hope we need to stop the aging process, to get better, and to live. Everybody's married in here, pretty much. Yeah, we have all grandchildren, great-grandchildren, great-great-great-great-great-grandchildren. Let's go down. Starting you, George, just tell us, what can we do right now? Give us some great advice.
Okay, I'm from the Mediterranean area, so I have to tell you, follow a Mediterranean diet.
All right. Dr. Shaya, go.
I'm going to just echo what Dr. Fields said. Exercise. Physical exercise has been the only one thing that has been proven to be the most effective in keeping the brain healthy, better than anything else. So exercise, and just refuse to think about the number of your age. Just keep on doing all you can do.
Judy, he just stole your line.
To echo that, exercise, and for what you were saying earlier, especially with the concern for the osteoporosis, weight-bearing exercises, squats, standing, walking, and walking is one of the best exercises aerobically for your weight-bearing, your everything. So walking is wonderful, and keeping a fast pace with your walking. Don't feel you have to go slow. Quick-paced walking at a nice gait speed are found to really encourage life and prevent falls. It's very, very important.
How long and how many times a week would you advise?
At least 3 days a week, 20 minutes at a time, if not longer.
5,000 steps?
Yeah, that sounds good.
So you'll be there in California by mid-August. That's good. Doctor, what would you advise? Give us some great stuff.
To live a happy life. I think many people have already lived a long part of a happy life. If you really want to be happy for a week, take a vacation. But I think if you want to be happy for your life, you have to be involved in your world. So you have to be engaged somehow. The people who stay engaged, who help others, are ones who probably will live longer and better and happier. So that would be my advice.
I like that. One more question. Doctor, DNR. What is a DNR?
So anybody who arrives in the hospital, one of the questions that has to be answered is what happens if things don't go well and you lapse into a cardiopulmonary arrest. The standard procedure, which was designed for 20-year-olds who fall through the ice and you can pull them out and resuscitate, never designed for 80-year-olds with multi-system failure, but it's still a question of whether we will put them through a CPR, mechanical CPR, put a tube down their throat and connect them to life support. The last thing I usually talk about when I talk with my families, because I'm always interested in the overall goals of care and what they are interested in for whatever valuable time they have. What happens to them when they die, or we're going to try to bring them back to life, is actually a least important conversation for me.
Adrian, your advice to all of us.
I would just say keep a vibrant community of people around you who you can talk to if you feel frustrated, who you can ask for help, and fight that urge to do everything by yourself and ask other people for help just as you would help them.
That's great advice. Ask, throw a hand up. That's it. Yeah. That is great, isn't it? Weren't they great? Our panelists here tonight, thank you. Our experts. We rely on you. Thank you. That's great. So we got to pay bills. I'll never forget anything, and I'll whatever. I want to bring up the great Brad Chambers, who is president of MedStar Good Samaritan and MedStar Union Memorial Hospitals, for a few words before we say goodbye.
Thank you, Jamie. Appreciate it. Good evening, everyone. On behalf of the Board of Directors of MedStar Good Samaritan Hospital, I want to thank you for all of our members in the audience tonight. Great presentation tonight, and this really adds to what we're doing at Good Samaritan. Samaritan Hospital. It's about educating the community, providing that level of awareness, and I hope that came through tonight with this distinguished panel of representatives that we had here. I am so pleased to provide this level of service to the community on a very important topic, because as we see our population growing older, we need to make sure that we're better positioned. So once again, on behalf of the hospital, thank you, and a special shout out to all of our wonderful members of the hospital auxiliary that could be here tonight and could join us here tonight in our audience. So thank you for being here. And as always, I want to thank our wonderful media partnership, WMAR and Jamie, for facilitating tonight. Jamie, thank you as
sir.
always
Always
for being here. We're going to be signing off here shortly, but you could always come to our website at MedStar Good Samaritan Hospital for additional information, and look for information on the Center for Successful Aging coming to you shortly here at MedStar Good Samaritan Hospital. I want to thank all of you and have a wonderful evening.